Now, if a patient does comes with hip joint osteoarthritis, what are his or her clinical features? There are certain things which are very particular about the hip joint problem. For example, patient is having a problem when patient moves, that is the antalgic gait. Our patient also had an antalgic gait. And what exactly is an antalgic gait? As you know, that there are two phases of gait. There is a stance phase and there is a swing phase. When both feet are on the ground, that is a stance phase, and when one feet moves ahead of another, this is actually a swing phase in simple form. Stance phase is when you are standing with during your movement. As this is painful, the patient usually quickly goes from stance phase to the swing phase. Therefore, when you do the gait analysis of these patients, normally a stance phase is about 60% and about 40% is your swing phase. In these patients, the swing phase is prolonged and the stance phase is reduced. Why? They don't want to weight bear on their hip joint. From as soon as they both feet are on the ground, they quickly take the next step so that they don't have to bear weight on this hip joint. And this is classically called as the antalgic gait. And usually when they are actually standing, sometimes you see they're tilting towards the opposite side. The reason is that when they're tilting towards the opposite side, they're actually reducing the joint traction forces on that joint. For example, our patient was having a problem and she was also leaning towards the other side. The reason is that she was trying to distribute weight in such a way that more weight as our axial loading is going through the other joint rather than the hip joint, which is actually problematic. This is they usually have a tendencies to move in a certain peculiar fashion, which can also give us a clue that probably the hip joint is problematic. For example, the same patient, if this patient would have some form of a lumbar pathology or ankylosing spondylitis, patient would have a problem with forward bending or backward bending, then you would have the problem would be more common of neurological claudication rather than any sort of this problem. The patient may be saying that, okay, I can walk, but there is pain, especially when I stoop forward and walk, the pain disappears. So that actually would have that would have rang your bells in your head that probably something is wrong with the lumbar spine. But when the hips pain, the patient when sits forward and there's no weight bearing, the pain disappears. But whenever he or she actually walks, that is where the real problem starts and the gait becomes antalgic. Now, what are the clinical features of the hip osteoarthritis? The first and foremost is always the limp or antalgic gait. There is always stiffness at the hip joint because muscles become tight, there's pain, and she's trying to put less and less weight on that side which is involved, and the more actually weight is going towards the other side. This actually puts the muscle in a certain position, and they may eventually increase tone and eventually leading to some form of stiffness and antalgic limp. Then disturbed sleep. Why? Because cartilage degeneration actually starts a cascade of inflammation, and this inflammation cascade can continue even when the patient is having a non-weight bearing. Although the precipitant factor is mainly mechanical, the problem started with the biomechanics, but once the cartilage wearing out starts, this is purely a biological problem, and then once this biological degradation of cartilage starts, the patient can have highly problematic disturbed sleep as well. Now, coming to the antalgic gait, as I've just briefly told you that the gait has swing and a stance phase. In these patients, the stance phase is actually reduced, especially when they are weight bearing on the side which is involved. And if it's bilateral, they have a very short stance phase, and morely this is towards the swing phase. And then they usually have tendency to sit rather than to stand for a long period of time. And then there is maybe associated loss of motion as well. The loss of motion could be there could be associated loss of internal or external rotation, or there could be loss of flexion or extension of the hip joint as well. What is important over here is that because the hip motion is painful, this articulation becomes painful, therefore patient has the tendency to decrease the motion at the hip joint. There could be loss of internal rotation, or there could be fixed external rotation contracture as well. For example, if the internal rotation was painful, patient will try to avoid that pain and keep the hip in more external rotated position. For example, the patient had scaphy at the adolescent age. Patient developed this sort of a problem, although that was corrected, but now the patient is having osteoarthritis, and whenever he or she tries to internal rotate, this starts having a problem. Therefore, she will have a tendency to avoid that pain. She will keep the hip in fixed external rotation deformity. And eventually, once the contractures develop, the patient may actually, the main complaint may be that the patient has this sort of a contracture or fixed deformity rather than the antalgic gait or osteoarthritis of the hip joint. Then there could be problem at the flexion deformity as well. For example, as the patient keeps the hip in slight flexion, this actually what happens is when you're bending forward, for example, then actually the weight shifts forward. When the hip is in slight flexion, the weight transfer is such that there is actually less weight being transferred through the hip joint. As a result, these patients have tendency to keep hips slightly flexed, eventually leading to sort of a fixed flexion deformity at the hip joint and fixed flexion contractures. Now, when we are assessing that, we need to rule out is this fixed flexion contracture due to hip joint, or there is something wrong with the pelvis as well. For example, in the case of ankylosing spondylitis, there is actually pelvic obliquity which is causing compensatory fixed flexion contracture at the hip joint. So whenever you are assessing the hip joint, you have to also keep in the mind that there could be something wrong at the sacroiliac joint as well. Therefore, when we are assessing a patient with these clinical features, we have to keep certain differentials in mind, and lumbar pathologies are among the most common differentials of hip joint osteoarthritis.